Hello, everybody. This is Molly Graziano. I want to welcome everyone tonight to a really exciting live stream event. It's going to be finally one of those events where you get a lot of the questions that you've all been asking me on social media, that you're talking to Katie Sue about, that you're talking to Elia about. So we're going to have a great conversation here tonight. And while I'm welcoming everyone, I would love to have you all pop into your comment section. Let us know your first name. Let us know where you're checking in from tonight. If you've come to this issue for any particular reason and you feel like sharing that, please feel free to share that. We would love to have you guys be, as interactive as possible. You're going to see some folks from our different state organizations are going to be on, being able to have conversations with you and hopefully going to help us answer some questions that you might have that we might not be able to get to tonight. So we'll go ahead and we will get this show started. Hey, saying thank you. Samantha's here from Atlantic City, New Jersey. I'm heading to New Jersey tomorrow. So my name is Molly McMahon Graziano. I live in Cleveland, Ohio, and I'm the community manager for Death with Dignity, but also the director of outreach for Ohio End of Life Options. And I'm going to be your host tonight. Most of the talking is going to be done by Katie Sue and Elia because they're the ones with the information. I've had so many wonderful conversations. I'm talking with folks online, and people are always like, "What about this? What about this? What about this?" So this is really going to be a unique opportunity for us to actually talk to people that are on the front line, talking to patients, talking to families, talking to healthcare professionals. So both have unique roles. So my first guest is Katie Sue Van Valkenburg. Katie Sue is the Medical Aid and Dying Coordinator for Denver Health in Colorado. And she is being joined tonight by Henry Butters. And I think, yeah, that is Henry Butters. Henry Butters is an intern. He works alongside Katie Sue in helping to support families and patients. So thank you for joining us, Henry Butters. We're glad to have your input this evening. And my other guest is a good friend of mine and a colleague, and her name is Elia Lawatsch. And she has been with Death with Dignity for over 6 years and is just a fountain of information on so many things, Death with Dignity. So we're looking forward to getting her impact tonight. But rather than me try to describe and tell you what these folks do, I was just going to turn it over to them, let them introduce themselves, and then we'll go ahead and get the conversation started. So Katie, do you want to start?
Sure. So I'm Katie Sue. I'm located in Denver, Colorado. And as mentioned, I am the program coordinator and a medical social worker at Denver Health for their medical aid and dying program. So my job is a variety of roles, but mostly walking alongside people who are accessing the legislation. My most honored role is to make this easier for people. I know that this is a huge life decision when people decide to utilize medical aid and dying, and my whole job is to make it easier and as least traumatizing as possible so that everybody involved in the process can feel supported as we enter this really sacred space of accessing this really beautiful law. So that's me.
Thank you. Elia?
Hi, I'm Elia Lawatsch. I work at the Death with Dignity National Center, and I'm our communications manager. A big part of my role is I also oversee our social work program. So we, slightly different than what Katie does, we don't work directly with patients in the sense of providing that care, but we do provide information. We connect folks with referrals to people like Katie, and we answer over 2,000 calls and emails a year. We provide information as far as like what the law is, how to find a doctor, and we're sometimes the first point of contact. Once a patient or a family member finds out about a terminal illness, they will call us first. So we really try to give all that information as holistically and in the most helpful manner that we can.
Fantastic. So I've asked Elia to kind of kick us off tonight and go ahead and give us an overview of the current states and jurisdictions that have laws, and also then the criteria. So Elia, could you give us a little bit of background before we get started?
Yeah, of course. So Death with Dignity is an option in 11 jurisdictions. There are 10 states with laws. Montana also allows it, but they do not have an actual law. It was a court ruling. Thank you for putting the list up there. I will let everyone read it. There's no way I was going to remember that off the top of my head tonight with mom brain. So basically, the laws are all very similar in each state. There are slight nuances, but essentially the criteria is the same. So in order for a patient to access death with dignity, they would need to be terminally ill, and that's with a prognosis of 6 months or less to live. And two healthcare providers would need to confirm that prognosis. They need to be over 18 years old. They need to be a resident of a state. Thank you, Molly, for the list here as well. They need to reside in a state that has a death with dignity law. This is true for every state except Oregon. They recently changed the criteria for residency. They must be able to make their own healthcare decisions. So they can't have anything that's impacting their judgment or their ability to freely make this decision. And of course, that's confirmed by their doctors as well. They must be able to take medications without assistance. So a doctor does not help administer it. They cannot get help from a family member or another care provider. They have to be able to take the medication without anyone helping. The patient must be able to go through the process the entire time. So you don't just meet this criteria at the beginning and then 15 days later no longer meet the criteria and still be eligible. It's really important that patients and their loved ones know that they have to meet the criteria through the entire process. I will add a little plug for a really awesome tool on our website. We have something called the State Statute Navigator. And if you're curious about how the laws vary slightly or want to read what's going on in your state with the law, you can go in there and really break it down by words and phrases to see the law in a more accessible way, we think, than having to just read the straight law off of like your legislative page.
Great. Thank you so much. Yeah, you can just go to deathwithdignity.org. You'll see a little resource at the top called States. And it's like Elia said, it's a great way to kind of just get like one-stop shopping to kind of see what's happening in your state and what's going to be happening. And you want to stay on top of that because things are always changing in your state as well. So one of the first things that we talked about today when we were getting ready for this exciting event tonight was I just wanted to know from Katie Sue and Elia, like what is the most common question that you guys get? Because obviously Katie Sue is dealing with a different population than Elia's working with. So I think these unique perspectives will kind of be able to really kind of fill in the gap between where the public is coming from, where potential patients are coming from, and then obviously Katie Sue's working with patients and families directly. So Katie Sue, do you want to start? Can you hear her, Elia?
Yeah.
Okay.
I was muted because Henry wanted to input something when Elia was talking, so we had to censor him a little bit. So anyway, to go back into how I was enthusiastically talking before, I get asked a variety of questions. So I'm kind of the front line here in Colorado. People often call just for information. And I think the biggest one is, what is MAID? Is this suicide? What is listed on my death certificate? There's a lot of questions about kind of the consequences or what the next steps are to accessing MAID. So that is one of our biggest conversations of what the difference is. And, just to address that really succinctly, MAID is for somebody who is terminally ill with 6 months or less to live. Somebody who is accessing MAID is going to die regardless. MAID accesses or allows them to have some dignity in those moments and has some power back in a moment when they've lost a lot of their power and independence to choose the time and the date and really lessen the amount of trauma that it might inflict on the family and the patient themselves if the disease continues to take its natural course. The difference there, kind of to outline it, is medical aid in dying is for somebody who is going to die but wants to have power in that moment. Suicide is somebody who is not terminally ill with 6 months or less to die and wants to die. I am never one to say if suicide is good or bad. I'm just saying from a law's perspective, MAID protects you. It's protected healthcare information that will protect you, your family, any of your assets, because I know that's sometimes a worry for families, but mostly stigma. People are very worried about what someone may think if they know that you took a medical aid in dying medication. And my biggest thing is that no one has to know, and we can talk about that later in the evening, but this is your choice. My program is all about giving power back to people when they haven't had power in a while and giving them that opportunity to make the choice. Do I want to tell people? Do I want to use my story to help further legislation after I die? Or do I really want to keep this close to my chest to protect me and my family who may not understand this decision? So I would say that's the biggest question I get. And then just to go back to the beginning of the death certificate, that's another huge worry for people. MAID is never listed on the death certificate. Again, protected healthcare information. So the death certificate will list your terminal illness. It will not list MAID. It will not say that you took any kind of medication. And I think that's huge peace of mind for all of our patients. So that's one of the biggest questions.
Yeah. I would say I'm really glad that you said that, because I talk to a lot of people online on social media, and people are always worried that the death certificate is going to say suicide, and then that's going to negate the ability for their loved ones to be able to go ahead and access their life insurance. It's really one of the biggest misunderstandings that's out there. And I've always kind of thought of it in terms, I know it's not apples to apples, but it's like if someone is dying of cancer, but happens to be on artificial support, and that artificial support is removed, that person still dies of cancer just because the artificial support was removed. So I know it's not an apples to apples, but it's kind of a little way for people to kind of understand really what the difference is, and that your loved ones do not have to be adversely affected because you've decided to use medical aid in dying.
Correct. And I love that example. It's just a tool. It's a tool in the toolbox. In Colorado, it's called the Colorado End of Life Options Act. So this is just an option, and it's an option that gives you your power, and it's an option that you don't have to tell anybody about. And I think that's really beautiful.
Exactly. Great. Thank you. Elia?
Yeah, it sounds like we get a lot of the same questions. Of course, you're working with folks who are in Colorado. We're working with folks across the nation. So I would say one question we get that you might not always get is, I live in a state without death with dignity or without medical assisted aid in dying. How do I get to a state that has it? What do I do? Is that possible? So of course, we always preface, our team does not give medical advice. We are not clinical providers, but we give information and allow people to use that and make empowered decisions on their own. So I'll usually do a little kind of fact checking with folks and walk them through some questions. I usually preface it as, this is an option. People have done it. We have heard successful stories about people doing it, but once folks usually start the process, I've often gotten callbacks of, this is not for me. This is not going to work out. It's too expensive. I'm already terminally ill. I have other things to worry about. Physically, I can't do it. And that's a choice everyone needs to make. But we'll start explaining, things like, do you have a state in mind? Where do you want to go? Do you already have a loved one there or a connection of support? I think that is vital. If someone's going to move out of state and do this, they're not moving to an entirely new state where they don't know anybody. It makes the transition a lot better if they can move to a place that they're familiar with. Some people will travel home or move back to a state where their kids have moved to, or they'll move to a state where they went to college. So they already have some kind of connection there and a support system built in. We'll ask folks too if they already know a doctor there, if they have made that outreach call, because that's really important too. I would never say, you should just move and figure it out when you get there. This is not something to be casual about. So consider finding a doctor first. That's vital. Set up that first appointment. Most doctors, especially in a COVID era, are doing telehealth appointments, and talk to them about your situation. See if you think you qualify, if they're willing to work with you, if they work with patients who are pursuing death with dignity. That's really important to make that first connection and then start the process of considering to move. It's also important, I think, to talk to that doctor about what they're going to need to see to prove that you're a resident. Of course, moving to a new state, everything's a little different with proving residency. With death with dignity, things can move faster. You're exempt from like a 6-month or a year waiting period, like you would be with some other programs or benefits. So I always say, really ask that doctor, what forms of my identification are you going to need to see to prove that I'm now a resident? So you don't have to do more work than you need to, or slow down the process anymore that you need to. So another thing we can do for folks is, once they kind of think about it, if they call us back and say, I'm going to pursue this, we can help with referrals. So a lot of states that have laws have really awesome statewide organizations that work directly with patients in accessing care. Or there's resources like you, Katie Sue, that we would send people to if they're like, I'm going to Colorado. So there are great networks out there that we can help connect people with. There's referral systems for patient to doctor referrals for patients who qualify. So that's also where we can help step in and connect people to the resources they need to make those next steps.
That's fantastic. Thank you so much. Because I think one of the things that you need to consider is, like, when people are out looking at the state pages that we have is like you said, knowing what the residency requirements are for a state. Like, for example, Katie Sue, how would that work in Colorado?
So in Colorado and in most of the states that require residency, it's a very gray area by the line of the law. There's not like, it doesn't say specifically state ID. It doesn't say you have to have filed taxes for 3 years. It's very gray. For our program, we ask that a patient have a state issued ID. So that can be, it can be the temporary one, but it has to be issued by the DMV. And that does mean that you are established somewhere in the state of Colorado as a resident. In many cases, some people have moved, like Elia said, to be closer to kiddos. And for those, we have different requirements. We ask either for a lease of the assisted living that they live in or the nursing home where they live. We ask for any like tax documents that they may have filled out because they might still have, a Florida ID or another state ID. And those do suffice. So it is a gray area, but we do require proof of you having some kind of roots somewhere in the state of Colorado. And I would, again, ask the doctor that you're talking with and see what they require. But like, it's a gray area state to state.
Yeah. Thank you so much. And I think one of the things that I kind of see as we're passing more laws across the country is states starting to talk to each other to say, how do we make this process easier and more accessible for patients? And I think as we pass laws in more states, I think that's going to improve. Mm-hmm. And so one of the things, again, I'm going to, put on my riled up hat here a little bit, because frankly, no one should have to leave their state to be able to die on their own terms. And that's really what Death with Dignity National Center and Katie Sue and Elia and all of us, everybody here on the call tonight really wants to see is that someone can stay home in their own state and get the health care that they want and be able to have that autonomy to make their own end of life decisions. So that's the end goal, but we know that there's things we have to work around in the meantime that patients want to have access to. So one of the things you both kind of mentioned earlier is one of the questions that you get a lot is why do doctors refuse to participate? So I'm really curious to know what your thoughts are on that and how you communicate that to people or what you say.
Yeah, I can go.
I'll jump in after you.
I can start, I guess. So if you didn't know, it's also written into the law to protect anybody outside of the scope. It doesn't just affect the patient. The law also protects anybody who might be affected by medical aid in dying. And what that means is that anyone can opt out of supporting somebody who wants to take medical aid in dying. The provider never has to tell you. They often will be fairly honest. Sometimes it's for personal reasons. Sometimes it's for religious reasons. But they don't have to have a reason at all. And the law protects them. It's not malpractice. But they do have to tell you, I'm not a practitioner that's going to support medical aid in dying. That's where I would suggest if it's your primary care doctor that you're talking to, go to ACA MAID, go to Death with Dignity, and find somewhere that you can get connected with another doctor who might be able to support you. What I'll add to that is that it doesn't just affect practitioners in the medical setting. That can also mean people who operate skilled nursing facilities, who operate assisted livings where many patients actually live. They can opt out and they can say that patients cannot take medical aid in dying within the walls of their facility, and that is their right. Does it make me upset? Yes. As a woman, it makes me sad. It was mentioned earlier, no one should ever have to leave their home to access MAID, but I also respect that that's part of the law. I want to respect some practitioners, some facilities. It's just not in their scope. So what I also suggest that if you are somebody who is looking into MAID either for yourself or for a loved one, ask everyone in their circle who can and can't support MAID. If they're living in a facility, ask that question. Can they take MAID here? If they're on hospice, ask the hospice, what is your medical aid in dying policy? Some hospices will not support a patient who is going to take MAID, which is hard, but that means that you might need to discharge that hospice, switch hospices. It may even affect your death day. So some hospices cannot be in the home at all when a patient takes MAID. Some hospices have to stand outside the door. Some hospices can be in the room. So it's good to know who's allowed to be in the room based on their policies and their personal preferences. That also goes for friends and family. You as a human are allowed to say, I really don't understand this. I'm not sure I can be in the room with you at that point. And that's okay. Again, we are here to create a safe space and a dignified death for someone. And dying affects so much more than just us. It's a whole system that is affected, and we want to make sure that everyone has the right to opt out.
Fantastic. Thank you. Great. Perfect. Okay. And tying in with that is one of the things that I see a lot on social media, and is that you either, well, we already have hospice, so you don't need the others, or people seem to think it's an either or, and they don't realize the continuum of really what's involved with hospice and palliative care and medical aid in dying. Elia, could you kind of touch on that a little bit and tell people how that can all work together?
Well, I think, yeah, the short answer is they can all work together. So Death with Dignity or Aid in Dying is an option that people can utilize in accordance with other options. So if they decide to pursue Death with Dignity, that doesn't mean I have to get out of hospice or I can't use palliative care. That is a myth. That is not true. People call us and we level set that all the time. So in fact, over 90% of patients who access aid in dying, they are also enrolled in hospice. So I think if I were a patient in this term, I would use everything I can to make my life more comfortable, to get all the resources that I can for myself, to support my family. And that means using hospice if you want to use them, and use palliative care, and really bringing your whole network together as your team. They're not all working in silos. And I also, just to back up a little bit with the last question, I wanted to add too that people don't always realize that the doctors you can work with to access aid in dying don't have to be specialists. So if you have cancer, you don't just work with an oncologist. Any doctor or healthcare provider, I'll call them, because now in New Mexico, of course, we've expanded what the definition is of who can prescribe. So I think people should really be aware that if you are wanting to pursue aid in dying and your doctor won't work with you, ask all your doctors. They can be licensed in anything as long as they're licensed in your state to practice. So I just wanted to throw that caveat on there. Sorry to derail where we're heading with hospice.
No, it's not. That's actually a good point, because I live in Ohio and I ask every single doctor that I go to. I tell them what I do for a living, and I ask them how they feel about medical aid in dying. And as a one-on-one meeting, most of them are very supportive, but obviously their hospitals may eventually have policies and things when we pass a law here in Ohio that we're going to have to deal with. But again, the more laws we pass, the better education that we do in the healthcare community. I think a lot of these things will get better over time. We're still kind of a new movement, and it's still kind of a new concept to do medical aid in dying. So I'm actually heartened by just the positive response I get in a state that does not even currently have a law. So don't be afraid. If you live in a state without a law, it can tell you a lot about your practitioner. When you find out how they feel about end of life issues, it can really give you a little snapshot into the psychology of how that doctor would handle things if you ever needed to have those kinds of conversations with them. So it's a neat thing to just kind of ask them anyway.
Yeah, no, I think people ask all the time, years in advance of when they would actually need it, just so they know if their doctor is even willing to do it. I know a lot, I've bounced around doctor to doctor as I've moved across the country, but I know some people really have their same general practitioner for 20, 30 years. So I think it's really good to know that ahead of time.
It is. It really is. Yes, absolutely. Thank you so much. So,
and I would also add on real quick is that I would always encourage your people, whether that's your healthcare team or your hospice team, to ask questions themselves. So a lot of state programs offer educations. I know that Death with Dignity, Compassionate Choices, Denver Health, we offer educations to hospices, practitioners who want to be prescribers and don't know how to help or don't know the law. So ask them, like, are you willing to get an education? And we can connect them with whoever they need to talk to so that you can get support from the person that you trust. But then also know that there might be other resources. So Denver Health offers the entire process very succinctly. The one thing we don't do is determine the terminality of a patient. So we depend on your primary care doctor, not to say that they support MAID, but that they have a prognosis for you of 6 months or less. And that can be a really great way for us to work together and maybe make it easier for you to continue care with your primary care, saying, I found a team who can prescribe me the meds, but are you willing to write that prognosis for me so that I can start my process? And we love working with the practitioners. They know you best. We work with them the entire time. Many of them attend the ingestion. So there's usually a way to involve your favorite team if they don't necessarily support prescribing the meds.
Okay, great. Well, that's good to know. I actually wasn't aware of that. So that's actually super duper helpful. Now, Katie Sue, I know that you've actually, you kind of take folks from the beginning all the way through. Can you give us a very short, but
Very short.
of what that looks like if it to give our audience a little bit of an idea of how that process works and how the time frames and everything are.
Yeah, and this will be very, very short. So if you have more questions, please reach out to me. But the medication itself is a compound of powders of very strong medications that would be effective in killing you alone, much less if they're combined together. But they are a third of a cup of powder that you mix with 4 to 6 ounces of liquid of your choice. It can be apple juice, orange juice, rum, whatever you prefer. And then you drink it in 90 seconds or less. At that point, you're going to fall asleep fairly quickly. The medications are designed to shut down different parts of your body. So there's something to stop your respiratory system, something to stop your circulatory system, and a few others just to help with comfort. People typically fall asleep in 5 minutes or less, and it's a very deep sleep. It's very graceful. I've worked in hospice and seen death up close personally and professionally, and it's not always pretty. And MAID deaths are beautiful every single time, and it's breathtaking. And then from there, the patient is unconscious, and they could die anywhere from a few moments after drinking the concoction to 10 hours. There's really not a timeline. It depends on the person's progression of disease, age, the abilities that they have, if they're on oxygen, all of those are factors. But the one story I'll tell succinctly that I think really encapsulates how beautiful it is. A patient with ALS took the medication. She had been very contracted for a lot of years because of her muscles and the disease progression. Her husband hadn't been able to hold her hand for probably 5 years. After she took a medicine, we physically saw her relax for the first time, and he got to hold her hand for the first time in 5 years without it hurting her before she died. And I think that's just the most beautiful encapsulation of what happens. It is an expedited dying process, but it's very graceful in a time when a lot of things haven't been so graceful. So I'm a huge proponent. I love to tell people what it's like. I really want to reduce the amount of fear, especially for those supporting other people taking MAID.
Well, thank you. So that kind of leads me to we'll wrap up here a little bit with our last question is family dynamics and who do you get involved? How do you talk to your family about this? So Elia, do you get phone calls from families inquiring on behalf of patients?
We do sometimes. It'll be, my loved one's considering going through this. I don't understand it myself. Can you explain it to me? So sometimes it's just setting the record straight, essentially, for folks who have heard that someone's going to go through it. I would say most of the calls I get from family members are after the fact. Part of a component of my job, which I haven't really talked about yet, is I do our storytelling program. So it is, I will say, I love every part of my job, but I'm just going to secretly say right here, it's my favorite part of my job. People call us every day and share their stories. They're amazing and they're impactful. And what Katie Sue was saying really made me think of that, of when patients, from the time sometimes they just find out that they're getting the medication, they get the prescription, they know they have this peace of mind now going forward, or the day that it's happening, that's what happens. There's a peaceful calm that comes over the room. And especially for the patient, they get to stop being in pain. They're no longer going to be suffering, and they have full control over every moment leading up to the ingestion. So I think those are the most of the phone calls I really get. I am, I guess, lucky in the sense that it's not usually calls of, I don't want my family member to do this, I'm in the way. That's probably more where Katie Sue has those tensions she could talk about. But yeah, I don't have to navigate that issue too often.
Katie Sue?
The one line, because I know we're coming up on 30, when there's a family member that knows that someone's going to take MAID, is struggling, and they talk to me, we always say this is the most selfless gift that you can offer your loved one. We can't do anything at this point. We can't cure their disease. We can't stop them from dying. So this is the most selfless thing you can do for them. Does it hurt? Yes. Is it hard? Yes. But this is the best thing you can do for them. And you don't have to understand it. We have lots of time to process, but in this moment, let's just give them this gift of being able to exit gracefully.
Well, what a way to tie that up. Thank you so much for doing that so neatly in a lovely little bow. I wish we could talk for another hour and a half, because I think we could. I'm going to hop on the comments afterwards. Elia and Katie Sue are welcome to join me. So please keep the conversation going. One of the things that I like to ask is, I like everyone, while you're here and while you're thinking about this issue, I like to make the bold request to ask you to take one action in the next 48 hours that is going to help move this issue forward across the country. And that can look different for different people. If you are not currently following us on social media, follow us on social media. Follow Katie Sue on social media. She does a really neat thing on Mondays called MAID Mondays, which I happen to really, really like. And you get neat little facts as you go along. I kind of call it bite-sized education. And I think that's wonderful. So follow us. If you're already following us, share a post. Help educate other people. That's where she works for a hospital system. We're a nonprofit. The best way that you can help is to help put that information on your page and let your friends and family then ask you questions. Or you can talk to somebody in the next 48 hours and say, I just attended this really neat webinar the other night, and let me tell you about it, because this is going to be pinned to the top of the page for Death with Dignity's Facebook page. So I want to encourage you to go back out and watch it. And if you can share it with your family and friends, that would be great too, because it does take a village, and it's going to take every single one of us advocating for ourselves and for people that we love to move this issue forward across the country. So thank you so much for joining us tonight. We thank you, Katie Sue and Elia. I greatly appreciate it. Henry Butters, we appreciate the cameo. Have a good night, everybody, and I'll see you in the comments section. Bye-bye.